Welcome to Critical Issues in EyeCare, an MD-OD conversation, hosted by Nate Bonilla-Warford, OD, and JC Noreika, MD, MBA. Critical Issues in EyeCare is brought to you by Marco Ophthalmic, a leader in vision diagnostic equipment. Now you know.
Hi, Nate.
Hi, Jay, and welcome to Critical Issues in EyeCare, an MD-OD conversation. In this series of podcasts, ophthalmologist JC Noreika and I are going to discuss some of the important issues facing eye care professionals. Today, we are talking with noted refractive surgeon Marguerite B. McDonald. Jay, would you like to introduce our guest?
Well, Marguerite's a superstar, but she may not remember this, but she and I actually sat at the Lancaster course in Waterville, Maine, those many years ago. Obviously, she's paid much closer attention to the cornea lectures than I did because she's made a huge impact on our subspecialty and professions. In 1988, Marguerite performed the world's first excimer laser surgery for myopia on a sighted eye. In 93, she went for the first hyperopic excimer laser treatment. She subsequently performed the first Wavefront treatment excimer laser in the Americas. She's an international lecturer. She writes proficiently and profusely and is currently holding clinical professorships at both NYU School of Medicine and Tulane University in New Orleans. Good morning, Marguerite.
Good morning, Jay.
You've been at the forefront of refractive surgery for many, many years. How and why does Wavefront data improve your refractive surgical outcomes?
Well, Wavefront data has solved so many mysteries. You may remember a few years ago when we couldn't figure out what was going on with a post-op patient. We would say it must be irregular astigmatism. We just, it was kind of a mystery. And then along came topography and helped enormously in that regard. But Wavefront provides lots of answers because you can find out exactly what higher order aberrations are troubling the patient and you can come up with a treatment plan.
So this is Nate, and for the listeners' sake, I'm a little bit younger than both of you guys. And for me, we learned about Wavefront in school, and I guess I pretty much take it for granted. I mean, I use Wavefront extraction evaluation on every single patient refractively to determine what's going to be the best option for them. So tell me just a little bit about how, when you look at data now, how is it different than when it was before? You've got so much available data. When I look at all the information on the OPD screen, I mean, there's screens and screens and screens. There's a tremendous amount of data. So how do you choose what you're going to be looking at that's going to be most helpful for that patient in determining what to do with refractive care?
Well, the diagnostic software on the OPD is extremely helpful. In the center of the printout, bottom center, it'll say this bears a 99% resemblance to myopic refractive surgery or to keratoconus or pellucid, etc. That's extremely helpful. The total percentage of higher order aberrations versus all aberrations is also useful. You expect, if somebody's got a very small refractive error, like minus 50 plus a quarter at 90, you expect that even in the healthiest of eyes, that percentage of higher order aberrations is going to be high because there aren't that many aberrations, period. There isn't that much sphere or sill. But if you have somebody with a high refractive error, minus 6, minus 8, etc., with a very high percentage of higher order aberrations, watch out. So, that you should start looking to see, does this person have keratoconus, pellucid, etc. The nature of the higher order aberration is a spherical aberration that causes different complaints than, say, coma. So those are the things that I look at the most.
Marguerite, is this what you do both preoperatively and postoperatively, or does something change in between as far as the post-op period is concerned? What do you like to look at postoperatively to know that things are going well?
Well, hopefully preoperatively you have ruled out any corneal dystrophy that would have made the patient a suboptimal candidate, though things are changing very rapidly now with the availability of cross-linking in the U.S., even though it is off-label, it's being widely used. But nevertheless, post-op, you have ruled out that the patient has any underlying condition that would give them a bad result. So now you're looking at the centration of your procedure. Did you nail it? Is it well centered? You're looking at the type of higher order aberrations. Do you have a lot of coma? You can also look to see dry spots. Actually, Wavefront maps are a great way to see exactly how dry your patient's eyes are. If they're having complaints that sound like dry eye and you've done their tear osmolarity, et cetera, you've evaluated them at the slit lamp, and now you see the classic sort of speckled, broken up pattern that you get from dryness on their Wavefront map, then you know you have to be very aggressive in treating that eye. So post-op, you're no longer looking to rule out pre-existing pathology. You're looking at how well did you perform as a surgeon? Is it well centered? And is this a dry eye, or was this, did something else interfere with the ablation? You can also see if there's a lot of coma, sometimes that's because the patient, say, had a large brow or nose, and the surgeon didn't tilt the head in the right way to get the airflow circulating over the cornea uniformly. So it's a great way to check your surgical technique as a surgeon.
So post-operatively, there's a tremendous amount of data that you can use to sort of assess what the outcome is. How do you use that data to educate the patient? And that could be in any result, because certainly myself and other colleagues who co-manage refractive surgery see patients who have what we think as a tremendous result, and despite the best preoperative education, their expectations may not have been realistic or met. So how do you use all this data to sort of educate the patient postoperatively?
Well, for instance, one of the most common post-op problems, whether it's LASIK or PRK, is post-op dryness. The dry eye doesn't last quite as long in somebody who's had PRK, but still, a lot of patients think that because preservative-free artificial tears and ointments are available over the counter, that they aren't important. So you show them the map, you say, look, the surgery, see this blue dot here? It's right in the center. The surgery was perfectly centered. And you see these numbers here, your plano, that means there is no prescription that would help you see better. But you see all these little speckles, this dropout here, that means your eye is bone dry. Those are dry spots, and it's ruining your optics. It's ruining the quality of your vision. So you can educate with them. You don't have to get real technical. It's a great way to educate, actually, not only to find out what's going on yourself, but it has tremendous impact with the patient, and it will get them to stick with the recommended regimen.
Nate, I would agree with Marguerite wholeheartedly in the sense that we love to pull these things up in the exam lane postoperatively to actually show people graphically with images. We are such a visual society now with so many screens facing us that they're very comfortable with that. And this does help in terms of having patients comply better with the post-op period. And I think it's invaluable as well, because if you can explain it in their terms, they walk away thinking that this is something that is far more important to do, dry eye treatment, for example, than they might otherwise. Images are so important.
Yeah, and if I could just deviate slightly from the refractive surgery component, because I see lots of children, so when I use the demonstration screen to show parents this is what your child's seeing, I think that has a giant impact on them. I use it almost daily as far as that goes.
Marguerite, you have been very instrumental in many different ways, and one evolutionary type of process is the Marco OPD3, which OPD stands for optical path difference. I wonder if you could expound a little bit for us in terms of how is this different from other earlier wavefront devices that you've used and seen develop over time, and what are its advantages?
Well, the tremendous advantage is that you can subtract out corneal aberrations from the whole eye aberrations. So you can find out, is there an early cataract that's making this 50-year-old so unhappy after LASIK? It is just invaluable at sorting that out. You know, by the time a lot of patients can afford to have refractive surgery, they're a little bit long in the tooth. They're in their 40s and 50s, and some patients even approach us in their late 50s or early 60s. Now, I personally am reluctant to do much refractive surgery on somebody over 55. There are exceptions to the rule, but usually you've got a lens that's starting to reduce the wow factor. You know, if they have an early cataract, they're not going to be thrilled even if you do the most exquisite laser vision correction. So you can use the OPD to sort this all out, and you can even show them. So sometimes, you know, the 54-and-a-half-year-old will show up and I'll say, you know what, you're just not going to be happy after laser vision correction because look, this subtracted out your cataract. This is how much of your eye problems, your vision problems are coming from your early cataract. So it educates me, helps me with better patient selection, but it also will help educate the patient. I say, look, you have an early cataract, you know, should we talk about refractive lens exchange instead?
Patients want to know all of their options, and they are very savvy. They've done research, they've talked to their colleagues, they've talked to their peers, so they're definitely interested in knowing all of their options, and so providing them with those options and, you know, and that having actual data to go along with it certainly makes them more comfortable and certainly improves outcomes. So I'm a little bit curious just to know how you see this branch of technology, not only as you're using it now, but maybe how you think things might continue to progress, because you know we live in an age where things change rapidly. So what do you think might be, you know, in maybe 5 or 10 years, you know, down the future as far as Wavefront? How do you think that that's going to impact refractive care generally?
Well, the Wavefront devices are picking up more and more high fidelity and more detailed information with each generation. So that can only improve the quality of the ablations. That's for sure. I think we will be using Wavefront technology sort of the way Calhoun Vision, a little company that's working on changing the power of intraocular lenses after they're implanted, and using the Wavefront aberration map after the cataract surgery to make a final tune-up, Wavefront-based tune-up in the power of the IOL before it's locked in permanently in the patient's eye. So all that lies ahead of us, and it's very, very exciting. And the aberrometers that provide the highest fidelity information will end up being tied to that surgery.
One of the things that we're seeing in a general ophthalmology community-based clinic are patients who are coming in now who are 20 years post-refractive surgery. There are not many of them, but they're building. And we're finding that the OPD refraction is a huge help in sorting out their problems in terms of, well, first-generation eximers, for example. As I said, there aren't many, but they're going to be building over time. And of course, Marguerite's very knowledgeable in regard to the excimer laser patients, the LASIK patients who are coming in who do need cataract surgery now. And I feel that this technology is going to help a great deal in sorting out some of those problems as well.
Absolutely. And you mentioned that the OPD refraction is helpful. It surely is. I think Dave Harden is the one who coined the expression WAMR, Wavefront Adjusted Manifest Refraction. So when you simply are having a tough time, with your 4-opter, stop, get the wavefront map, and all of a sudden there you are. It's amazing on these complicated eyes that accessed LASIK technology very early on, when it was extremely crude, and there were no centration devices. There was no iris registration. So these tiny decentered ablations from years ago can, combined with an early cataract, can really make it hard. So the WAMR has been very helpful in our practice.
Yeah, we don't even go to a 4-opter anymore. I mean, it's right to the Epic station, and these people get their wavefront. Well, I think that pretty much brings us to the end of this podcast. We all have missions to accomplish today. We hope that you have found it as enlightening as Nate and I did. As usual, we'd like to hear from you, our listeners. Please contact us via the website, the Marco website, which you downloaded this program from. We appreciate all of your comments and suggestions, even suggestions in regard to future guests and conversation. Marguerite, it was great visiting with you again today, and I hope to see you soon somewhere out on the trail. Goodbye, and I hope you'll join us again for Critical Issues in Eye Care.
I would love it. Thank you, Jay. Thank you, Nate.
Thanks, Marguerite. It was wonderful talking to you.
This broadcast is sponsored by Marco, redefining the art of refraction through superior understanding of every patient's total visual system. The Marco exfraction process combines wavefront technology with digital refractions to deliver outstanding practice efficiencies and optimized patient experiences.